Hello, this is Aaron Murphy, the Gazette's Des Moines bureau chief and host of the On Iowa Politics podcast. Here to let you know that there's going to be a different kind of episode of the podcast for you this week. As you can see from my virtual background, it is Iowa Ideas Week here at the Gazette. It's our annual virtual conference where we hold dozens of sessions on topics of importance all across our state, impacting all Iowans. And that project takes up a pretty good chunk of our time, as you might imagine, this week. And so a little bit too busy with those duties to manage the podcast as well. But because we have all of these great conversations happening, we thought let's share one of those with our podcast listeners, and one that's relevant to the beat, and a topic that our loyal listeners will be familiar with. So what we're going to share with you here this week is our Iowa Ideas session on addressing long-term care challenges in Iowa, obviously an issue that's very prominent and has been discussed by state lawmakers very frequently in recent years. So as a quick summary here, Iowa nursing homes face heightened scrutiny after reports of deaths, abuse, and neglect in recent years. This session will look at the issues and challenges facing Iowa's long-term care facilities, from staffing to training, family access, and security. It's a great conversation. Take the time and listen, and your regular podcast gang will be back with you again next week for our stretch run to the election. Thanks, everybody.
Hi, and welcome to Iowa Ideas Conference. In this morning's session, addressing long-term care challenges in Iowa, which is within our healthcare track. I'm Tom Barton, the Gazette's Deputy Des Moines Bureau Chief, covering Iowa politics, including the Iowa legislature and campaigns. I'll be serving as your moderator, helping to guide today's discussion and conversation as part of Iowa Ideas, which seeks to explore the issues, address challenges, and share the big ideas that will shape the future of Iowa. I'd like to recognize our presenting sponsor, ITC Midwest, which helps make this virtual conference possible. Just as a reminder to our audience members, you can submit questions to our panelists through the Q&A function. Also, this session is being recorded, and closed captioning access is available. As I mentioned, today's session is titled Addressing Long-Term Care Challenges in Iowa. Iowa nursing homes face heightened scrutiny after reports of death, abuse, and neglect in recent years. This session will look at the issues and challenges facing Iowa's long-term care facilities, from staffing to training, family access, and security. With me today are Angela Van Pelt, State Long-Term Care Ombudsman with the Iowa Department of Health and Human Services. She became the State Long-Term Care Ombudsman in June of 2021, and prior to that was the Iowa Department on Aging's Public Information Officer and Legislative Liaison. Just a bit of background about the office. It's a creation of the Federal Older Americans Act. It is set up to operate as an independent entity housed within the Iowa Department of Health and Human Services. And its mission is to protect the health, safety, and rights of individuals living in nursing homes. It does this by investigating complaints, seeking informal resolutions to conflicts, and providing advocacy on state and federal legislative issues. It also advocates on behalf of Medicaid managed care members who are enrolled in one or more of Iowa's home and community-based services waiver programs that help people with disabilities and older Iowans stay in their homes and communities. Welcome, Angela. Thank you for being here.
Thank you.
Also with us today is John Hale, co-owner of the Hale Group, Ankeny-based consulting, advocacy, and communication firm focused on older Iowans with disabilities, and the caregivers who support them. John has been a passionate and persistent voice on aging and long-term care issues in Iowa, pushing policies that enable older Iowans and their caregivers to lead the best lives possible. Welcome, John. Thank you for being here.
Thanks, Tom. Happy to join you.
Yep. And we have Sam Heibel, Director of Advocacy and Engagement at Leading Age Iowa. It's a statewide membership organization of not-for-profit aging services providers in Iowa. Sam became Director of Advocacy Engagement for Leading Age Iowa in July after serving as Director of Public Policy since 2022. Her background is in government, politics, and international relations. Welcome, Sam. Thank you for being here. All right. Again, just another quick reminder that questions for a panelist can be submitted through the Q&A function. So a bit of background and kind of a lead into this discussion. Iowa's nursing homes continue to be plagued by low staffing and high turnover. According to data from the Federal Centers for Medicare and Medicaid Services, 14% of Iowa's more than 400 nursing facilities were cited for insufficient staffing in fiscal year 2023. It's more than double the national average of nearly 6%. And more than 43% of Iowa nursing homes do not meet upcoming federal mandates on staffing levels, according to a new national report. Nearly 40 nursing homes across the state, predominantly in rural communities, have closed since 2022 related to staffing challenges and financial distress. Governor Kim Reynolds and Republican lawmakers who have received significant campaign contributions from the nursing home industry have highlighted efforts to ease regulatory barriers and increase Medicaid funding. Meanwhile, the Iowa Capitol Dispatch continues to run series after series of investigative reports uncovering abuse, neglect, and significant care and oversight problems in Iowa's nursing homes. Sam, I want to start this conversation with you. What are you seeing in Iowa's nursing home industry? What are the biggest challenges and obstacles you're seeing right now among your members?
Yeah, thank you so much. And you're right. This is an issue. These issues existed long before COVID and just were drastically exacerbated by the pandemic. So when I speak with my members, the two biggest things they say keep them up at night. First would be funding. In Iowa, 1 in 2 nursing home residents rely on Medicaid. Medicaid rates, there was a gap between the cost of providing care and those rates before COVID, and that gap has continued to grow post-COVID. In Medicaid rates in fiscal year 2023, there's an $86 gap between the nursing facility rates and the reported per diem costs. Even with the additional funds allocated in fiscal year 2024, reimbursement levels are still approximately 8 to 11% below the cost of care. So a lot of our providers are simply losing money every day with the care they provide. For workforce, as other industries have started to bounce back following COVID, nursing and residential care facilities are still 7% below what their employment rates were at the end of 2019. This is just a huge number. When you compare it to other sectors, even within healthcare, hospitals are up 2% from 2019. So while that's not where they probably like to be, and they probably feel short-staffed as well, aging services has just been hit hard by these two major issues.
So, as I mentioned, Iowa has seen, I think, 38 closures of nursing homes across the state in just the last 2 years. I guess what's contributing to that? What do these facilities have in common, and where are these closures happening?
It's a great question. As you mentioned, they're generally rural, generally small. Often single-site communities with a small number of beds, and the drastic increase in costs, the exodus from the aging services workforce, it's caused this perfect storm. There's this reliance on agency or temporary staff, which is extremely expensive. There's also regulatory strife for providers. A lot of regulations that don't exist in other parts of the healthcare sector following COVID are still plaguing long-term care providers, and all of these things have exacerbated these issues. What we see happening is when providers are starting to lose money or they can't afford to have a large number of staff, they have to lower their occupancy. They have to de-license beds. What happens there is then they can't take on as many residents, so they're not making enough money, and this is a vicious cycle that unfortunately leads to closure.
And then, so I guess the bigger question here is, what do these closures mean for older Iowans, not just now, but in the future needing care?
Yeah, I mean, it's really scary if you think 2030 in our state is going to be the first time we have more people over the age of 65 than below the age of 18. What happens, we see this in rural communities, is these care deserts exist where people can't get care in their communities. Oftentimes, it's the only aging services provider in their area. So their families either have to find a way to provide care in the home or have to send them to another community. Rural communities in Iowa are very proud. They don't want to have to go away from home. They want to be cared for by the people that understand their culture or understand the roots within the place that they grew up. And so it's caused a lot of strife, which either leads to burnout from their caregivers in the home or them having to go far away to receive the care that they need.
Yeah. Angela, as the state's long-term care ombudsman, how has your office responded to these closures?
Yeah, I think the main thing from our office perspective is that we want to minimize the level of transfer trauma that these individuals experience. So for them to be in a facility is one thing, and then to have to shift unexpectedly, to be removed from their community that they've come to know. They've come to know the staff. This is their home. This is where they live and they reside and they make their connections. We try to be there to support the level of choice that they have in this process. Now, obviously, if it's an emergency scenario, that's very different. Our role looks very different because that choice factor is sometimes removed. So then we're providing follow-up after the fact that they've been placed somewhere else on a temporary basis. But we really want to be there to make sure that the facilities understand, listen, they do have choice. And just because you have a sister facility, that may not mean that's the best choice for that individual. So we want to make sure that choice is respected. We want to make sure that families understand all of the dynamics that are going on. We want to make sure that they leave with their belongings, that they have the resources that they came into the facility with. And then we really want to be more proactive on the follow-up end of things. So we want to be able to report out, hey, this is what we saw during the closure. These are the impacts to the resident. And this is where we think we need to make shifts and adjustment in that process. So we're kind of looking at it from a holistic viewpoint as far as from the beginning of the closure to the end of the closure, but then also systemically, how can we work better together as state organizations involved in the process as well. So there's several different ways that we're involved in that closure process. It's a lot.
I can imagine. It's my understanding that your office has undergone a restructuring, and you've said in the past that your hope to chart a new direction for the office. I guess, what has that restructuring entailed, and what direction are you looking to take the office?
Yeah, that was a great question. When I started in 21, we didn't have a lot of activity in the field. Of course, we were just off the heels of COVID, but even prior to that, I don't know that visits had always been the top priority. And I think that was the biggest shift that I wanted to make coming into this role, was we needed as many people that we could get out in the field, actually doing the work, being in the facility, being an extra set of eyes as to what's going on. It's a totally different thing to have a phone conversation or to see you on a video screen versus actually being in that resident's living environment and seeing all of the things that are going on. And maybe there's, the smells in a building, the way that it feels, the interaction among staff. So us being in the facilities was the biggest priority. In order to do that, basically, I took all of the staff positions largely and turned them into field positions. That was maybe the biggest thing. Now we have a couple of other kind of offshoot areas. One of those was the managed care work that we do. And we've gone ahead and incorporated that into the role of the local, because I think that the individuals that we encounter, while we encounter individuals in facilities, we also may do work with someone that's in a hospital that's looking to go into facility. Or on the flip side of that, we may be talking to the individual in a facility that wants to return back home or return back to the community. So whether they're on managed care, whether they're a part of a waiver, we kind of can be that continual person in their life as they're navigating through those scenarios. So that's really one of the other things. We wanted to kind of incorporate all of those bodies of work that maybe have been a little bit piecemealed out within the program as a whole, and actually give the resources and the tools to that regional local person to be able to navigate their volunteers, to be able to navigate in the managed care world as well as the long-term care facility-based world. So that was kind of our overall goal.
So how many regional ombudsmen does the office have now working around the state? And I guess how does that compare to previous years and maybe other similarly sized states?
Yeah, we now have 10, which is the highest number that I think has existed in the entirety of the office. We are super lean administratively. So that means that we take on more at the state office level in order to allow that work to occur. It's hard to kind of gauge how that compares to other states because states have options as to how they structure their programs. So, for example, some states actually have the triple A's or another organization providing that service level. So it looks a little differently. I would say that compared to the ideal, which is around 2,000 beds per long-term care ombudsman, we are still very short on that. We're averaging close to 4,000 to 6,000 beds per ombudsman, if that gives you an indication of kind of the work still yet to be done as far as where we would get to a more ideal state in that.
And when you refer to AAAs, you're talking about the area agencies on
Yep.
aging?
Correct. Yep.
All right.
Tom, can I jump in here just for a second?
I was just going to go to you. Go ahead.
A couple of things. First of all, to be candid, I've probably been the most significant critic of the Office of the Long-Term Care Ombudsman over the past 10, 15 years, because I think that the criticism was warranted. But I want to say it here again this morning, what I've said many times before. Angela was doing an exceptional job at that office with resources that she has. She has 10 people out in the field. She probably needs at least twice that to really do the kind of work that I think they want to do, be very proactive, be out there in the field, not just when a complaint comes into their office, but when there are no complaints. Stop in and see what's going on. Talk to residents, talk to administrators. So I want to thank her for what she's doing. Thank her staff and what they're doing. But back to the question about nursing homes and closures and the current status, I think we need to back up and ask ourselves why this is happening. And a couple factors I think are working. It wasn't until the mid-1980s or so that we had even thought of, we talked about this concept. We now just take for granted, which is assisted living. Assisted living didn't exist. Assisted living facilities didn't exist until the 1980s. And there has been phenomenal growth in the living concept. I mean, you can drive around anywhere in metropolitan, both towns, wherever. Assisted living center, everywhere. I think there are now close to 100 assisted living facilities. And the other part of this, so they are, in essence, they're like competition. Nursing homes in Iowa, we have the highest ratio of nursing homes to residents any place in the United States. We have over 100 nursing facilities to serve population 3 million. That is more than states with 2 or 3 or 4 times population. So we got a lot of nursing homes. And we now have a competition for nursing homes in 460 homes. The other point to make is we used to think of nursing homes as the small tenement, faith-based, locally controlled, locally owned, people in charge who care about their residents in their local community. That has shifted drastically. In Iowa and across the nation, this thing we used to think of has now become a for-profit industry, corporate-controlled industry, an industry that now is viewed as investment rather than a public service. And when you shift from a public service to business public investment and bottom line, what you see happening is a lot of decisions are being made by investors to close facilities just because we're not making enough money. That's a drastic change. Not a good change, but that's the reality of the world that we live in.
Right. So as you alluded to, one of the issues impacting the industry is the growing role of private equity in elder care. So private equity ownership has different financial incentives and business strategies than other types of for-profit ownership, such as independent or publicly traded firms. I was reading through a working paper by the National Bureau of Economic Research, a nonprofit research organization that found declines in measures of patient well-being, nurse staffing, and compliance with care standard. And it talked about how private equity owners have what it said are high-powered incentives to maximize profits because fund managers are compensated through a call option-like share of the profits. And usually aim to liquidate investments within a short time frame and don't have existing relationships with stakeholders in the communities that these nursing facilities serve. I guess I'm going to direct this to you, John, and to Sam. How prevalent is private equity ownership in Iowa's nursing home industry, and how has that changed over the years?
So for context, John mentioned I believe the number is 404 nursing homes in Iowa. 169 of them are nonprofit. I don't know historically what the percentage or the statistic of that change would be, but I can say that it's a growing thing. You see more and more rural providers being purchased by for-profit companies, or expansion, or we do see it happening, absolutely. And what it does is it makes it so these companies that are in it to make some money or to receive Medicaid dollars, if they are bad actors or make decisions that are detrimental to the quality of what they see as a business and not as providing care, that the retributive action that's taken against them shines a light on the whole industry. And then it makes my not-for-profit providers that I support, that are acting out of their faith, their mission-based. They have boards that are based in their communities. A lot of them, their parents are going to go to that nursing home that they work at, and their grandparents have been there, and they will maybe be in there someday. And they care deeply about the strength and quality of where they work and where they work and who they serve. They end up bearing the brunt of that negative light.
Go ahead. I don't have any data, but nationally, private equity is tied in 5% of the ownership of nursing. The problem goes beyond private equity. Think about average investor, who's just looking for a good investment, can now buy into the part owner of what's called a REIT, Real Estate Investment Trust. There are REITs that's markets and nursing homes in a system of REITs and grow. This is a national 12% of the market. So you've got private equity controlling 5%. You've got REITs controlling 12%, all based off making as much profit as possibly can for the investors who choose to be invest. And then the bigger picture, you've got 70% of the nursing homes in Iowa, and probably close in Iowa, that are corporately owned. And even some of CM's 169, not probably 40 of those nonprofits act like a business, pay their executives like a business, provide service like a business, even a little bit, contingent here. So back, think about that. 70% corporately owned, 12% just REITs, right? The private equity. I mean, you can see why this is now entirely different kind of conversation than we've had 10 to 15 years ago. This is about business, about making profit. It's about bottom line. And it's not about serving the rest of it that we all care about. Somehow the residents get lost in these conversations, which is beyond sex and absolute tragedy.
So why are these, private equity companies choosing to invest in nursing homes? And what does that mean for the industry and the issues and challenges facing Iowa's long-term care facilities?
I think population, like I said, Iowa is about to be an inverted triangle, right? There's going to be an increased need for this kind of service, right? So they see it as an opportunity.
So that gets to something else, and John, I'll direct this at you. We've mentioned this. There's a so-called gray tsunami that's anticipated to hit the state in the coming years. I think by 2034 adults over the age of 65, or I guess 65 and older, are expected to outnumber children for the first time in U.S. history. Sam, I think you probably mentioned that earlier in this discussion. So, John, my question to you, with Iowa suffering from staffing shortages, facility closures, what will it require from the state to care for the next generation of seniors?
Well, I tell you, at least we got a care crisis now. And if we just choose to ignore the demographics and trend lines and what Sam knows and what Angela knows and what I know and what a lot of Iowans do, if we choose to just ignore that and not take action, this care crisis becomes a care disaster 20, 30 years down. I mean, it's like, there's a plane crash going to happen here. So do we deal with trying to prevent the plane crash, or do we just let it happen and then react? Tom, you can think about this as a huge problem, or you can also think about this as $1 billion. And I wish that state leadership will fit this as a huge opportunity. The reality is we got to get our arms in. We've got to start thinking beyond the next election cycle. We got to have some long-term planning here. We got to do some serious thinking about exactly this. How are we going to care for this aging the fastest growing segment in population, this 85 years of age up? The numbers are absolutely daunting, but if the governor and legislative leaders would say, this is important, this is a priority, we're going to provide some leadership here, we're going to pull together some of the brightest minds in the state of Iowa, give them a blank sheet of paper and say, design a system for us to live with 20, 30 years moving ago. I'm absolutely convinced that they could design that, they would do that, and they would not just be stuck in the current with the thinking that we got 400 nursing homes, we got 400 assisted living centers. They think about this in alternate, different ways, what people want now versus what people don't want when it's 30 years from now, into where services provided, how well, who does it. So we just model the leadership, big, bold, innovative leadership. And that's what it calls for. I hope we'll get it.
Sam, we touched on this at the top, but I guess walk us through nursing home financing and the financial burdens that Iowa nursing homes are facing. How can Iowa and the federal government work to ease those burdens, including financial barriers that commonly block in-home assistance or care at small nursing home facilities?
Absolutely. So, of course, if someone is going to receive aging services, there's private pay, meaning they have money and they can just write a check to pay for the care they receive. There's a small number of people that have long-term care insurance. That's getting more and more popular, but a lot of young people or middle-aged people don't necessarily like to think about their care when they're older, so they don't buy it. It's expensive, and then they get to that time of their life and they're not necessarily prepared. And so what's there to help fund care when someone reaches the age of 65 would be Medicaid or Medicare. So Iowa Medicaid determines nursing facility rates based on cost reports that include a case mix of their current residents. So the provider cost audit and the rate setting unit then determines the per diem rate for each facility separately. By law, nursing facilities are rebased every 2 years. So their rates on July 1 are supposed to reflect the current cost information based on what was reported previously. But just as you and I know, the price of everything changes and inflates almost constantly. That makes it so there's that difficult gap between what's being reported and then what those nursing facility rates actually are. And then for other types of care, like for instance, home and community-based services, by law, there is no requirement for rebase. So it could be 5 years before those rates are rebased to keep up with the price of how much it costs to provide things like in-home care or assisted living, which is an even greater gap. So every aspect of this costs more: supply chain issues through COVID, medical supplies, food. It's a larger burden on this gap that already exists. And then, of course, workforce turnover is also extremely expensive. It's way more expensive to hire someone new and train them than it is to keep someone on for a long period of time. This also has resulted in a lot of agency staff or temporary staff usage, which charge exorbitant prices to our providers. Ways to ease these burdens, as simple as it sounds, Medicaid rates have to rise across the continuum of care. A lot of people, they can't access in-home care in their communities because there aren't any providers, so they end up being institutionalized earlier than they need to be because that's the only thing available to them when they're on Medicaid. So making sure that home care and HCBS rates are keeping up with those nursing facility rates. And then on top of that, making sure across the continuum, those rates are actually keeping up with those prices. More regulation is necessary for healthcare employment agencies. We saw this discussed during the last legislative session, but it's just necessary. The price gouging is absolutely insane. And while temporary workers are necessary with our current workforce crisis, we have to crack down on how much they're charging. And then other things outside of the financial, provider enrollment or even relationships with Medicaid and MCOs for providers who are already enrolled can sometimes be fraught. Disagreements about what was charged or the paperwork or filing things on time or whatever, that can lead to providers not being paid for cares, 2 years later after they've already submitted payment. So I think increasing education and improving the relationships between payer and payee to make it easier for providers to give feedback and get real-time information about the funds that they need for the cost that they're providing. Lastly, I think, as we talked about workforce, I think the state really needs to invest in wraparound supports for healthcare workers. This will lower the amount of turnover, making workforce less expensive for providers. Things like healthcare, housing, transportation, even Wi-Fi, we see has makes a huge difference in someone's ability to go to work and work a full day and then go home. I also think looking at other ways to expand our workforce, like access to education, and then immigration. We have providers that bring families over, and then they have an environmental services director, a chef, a charge nurse, and their families are integrating into their society, their communities really well. And that's working great for them, but that's expensive and fraught, and only providers with a certain number of resources can engage in immigration as a workforce tool. So I think also looking at both traditional and non-traditional ways to expand immigration as a tool in Iowa.
John, according to AARP, nursing home facilities that operate more like a home with a small number of residents are frequently more efficient, provide better quality care than large-scale facilities. Yet, as Sam was talking about, I believe most are paid for out-of-pocket, not covered by Medicaid, and keeping them out of the reach for most people. Meanwhile, non-medical in-home services that can allow elderly people to live in their homes longer also frequently require a special waiver or are not covered by Medicaid, and hundreds of thousands of older or disabled people who qualify for Medicaid are annually on waiting lists for home care. This week, Vice President Kamala Harris, the 2024 Democratic presidential nominee, proposed expanding Medicare, the federal health insurance program for older Iowans, so that it covers long-term care and includes services like in-home aides. How should lawmakers and regulators rethink how long-term care services are provided in the state?
Well, Tom, rethink is the operative word here. I think, first of all, elected leaders need to recognize that rethinking is necessary, which they haven't recognized yet. So that's kind of step one. I would go through and just talk about, the first, the most fundamental question here would be asking Americans, what do you want? As you would, where do you want to be? Where do you want to be? Who do you want to go here? And if you stopped 100 people on the street and just did one of those quick instant polling kind of thing, you ask them, where do you want to be towards the end of your life? Where do you want to be served if you need some help? I don't know if any said, I want to be in a nursing. I don't know anybody that would say that, but yet that's our public policy. That's been the way we operate in America in the past 34 years. I think what they would say is, I would say is, I want to be in my room as long as I can possibly be here. I want to be in my room. Anybody I want to be with. We got a lot of friends. I don't want to have to leave what I'm forever and go to some institution somewhere where I'm going to be like a box in the warehouse, not by every nursing facility. I'm going to beat this one on flesh and treat people extremely well. But that's kind of the common mindset that I don't want to go to some big institution. So I think if we start what people want and design a system around that, there are all kinds of people in nursing homes in Iowa that could be serving in their own homes if we had a vibrant, visible home community-based services. We're always going to need nursing homes to care for those really difficult cases. Sadly, Alzheimer's is a reality. It's a growing presence in their lives. People with Alzheimer's cannot be well cared for in their own homes. That's the sadness. So I think we just got to step back, do what the operating on really take hold, and design a system based on what they want and what they want in the future. Just, a lot of people talk to me and my wife about, when I get old, I want to buy a big house and I want to live with whatever my friends, and we're going to have kind of this community living, and we're all going to live in separate parts of this big house, but when we need help, we can bring help in. That's what I call the golden girls in Iowa, and that is some people are talking a lot. The auxiliary dwelling units that people are putting in, people that in the backyard, their grandchildren, but yet they can still live there and have some privacy. Again, it's all about what people want. We're not giving people what they want. We give them what we give them. And I think if we shift mentality here and start talking about let's meet their needs, we'll have an entirely different kind of service to look at.
Right. Just reminder again to our audience, if you have questions for our panelists, please submit that in the chat or the Q&A section, and we'll get to as many questions as our remaining time allows. So it's my understanding that the state Medicaid officials are currently working with the federal government to improve procedures and expand home services. Sam and Angela, I guess, what can you tell us about the home and community-based services waiver process and the redesign?
Do you want me to take that one, Sam, or start it out?
Okay. Go for it.
So I think that the redesign is really focused on a few different areas. And one is that streamlining of 7 waivers down to 2. And that process actually effectively takes out the kind of diagnostic part of it. So you're really kind of looking at more lifespan and the category that you fit within there instead of 7 different categories that you could fit within. And that will lead to kind of less administration. There will be benefits on that end too. Also, they're looking at more formal and informal supports added to that package. So, there are some things that I think get discounted when we're looking at a service package that is so structured that you don't have the ability to maintain practical ideas and build those into someone's care plan. And then also the tiered budget concept. So resources are allocated based on need. And that's kind of another different component that I don't think is always considered. So I think that, just making some major shifts, and those are kind of big deals, especially a streamlining of 7 waivers down to 2. That's a pretty big deal. So I think that all of those things are hopefully steps that will increase and expand the availability of those Medicaid waiver services. Just as a side note, there are also community-based services that aren't necessarily Medicaid related. And sometimes we kind of group all that into one big pot. And those other community-based services are really essential for those individuals not on Medicaid. So when we're talking about the system as a whole, we've got to look at that private payer too, and make sure that they have the supports that they need to stay in their home. So I think that, as we watch this play out, it'll be really interesting to see what that waiver and Medicaid redesign looks like, 2-3 years down the road.
House Republicans ahead of the 2024 Iowa legislative session said lawmakers must step up and protect Iowa's nursing homes and healthcare institutions. While portions of their legislative proposals were incorporated into budget bills, Iowa lawmakers failed to pass substantive nursing home legislation this year, including a bill backed by House GOP leadership and the nursing home industry to cap payment rates that staffing agencies could charge for their temporary nursing services. I guess I'll just throw this out to the panel. I guess, what does that mean for the nursing home industry, and what action could be taken next year?
Yeah, so I have a lot of thoughts. I have a lot of thoughts about this. We were extremely supportive of this bill. As I talked a little bit about Healthcare Employment Agency previously, just really price gouging our providers following COVID. And I'm happy to provide some more context for that. So healthcare employment agencies, there was a bill in 2022 that made it so healthcare employment agencies had to submit reports to Dial on how much they were charging, how much they were paying their people, and where they were based. I don't know if anybody looked through those, but last December when I was super pregnant, I looked through all of them because I couldn't do anything else. And I found a lot of really concerning information. So firstly, and these are based on the Q4 2023 numbers, of the 313 healthcare employment agencies registered with Dial at that time, only 19% supply temporary workers to long-term care communities. So that is a bottleneck that is ripe for price gouging, and that's exactly what happens. And I also want to say that this is not just bad for providers. This drives up costs, which ends up on the shoulders of Iowa's taxpayers. So it's not like this is an issue that is just affecting long-term care providers. It's every Iowan when we consider that we want to know where our dollars are going. If you review those reports, as to be expected, they're charging providers and only paying a fraction of those charges to Iowa's caregivers. So they're charging 82% on average than they pay each CNA. So you think about temporary workers, we think, oh, that's good. It's a way for a CNA to make a little bit more money. But these companies are the ones that are taking all this money. And on top of that, 62% of these companies aren't even based in Iowa. So of course we want to be supportive of free market. We want to be supportive of companies being able to make money off of the current environment. However, these companies are largely based in New Jersey and Florida. These dollars aren't staying in Iowa, and Iowa's caregivers aren't even making all that money. This money that providers are being charged, why don't we let all of that go to caregivers and who then develop a long career within those communities? And listen, temporary workers are necessary. Iowa is going through a workforce crisis. We need these companies to be here because at least for now, our providers are going to need them. But we can't let them continue to go unchecked with the amount that they're charging, as it's literally bankrupting providers all across the state.
I think I'd like to piggyback on that and actually touch on the quality of care that agency staff is able to provide. So again, we're not talking about individuals that are just like in a hospital for a 2-day stay. We're talking about individuals that rely on staff relationships to fulfill, a huge portion of their quality of life. So when you have someone that's coming in from an agency that, one, hasn't been trained within that facility, doesn't even understand how the facility operates or the layout of the facility, or really understand any of the resident needs, you can only imagine what that does to the quality of care within that facility. So you can have staffing in the facility and you can pay a higher dollar amount to do that, but that is going to directly impact the quality of care that the resident experiences through that, as well as it's just not a sustainable funding mechanism. I mean, it just is not a sustainable model. So those are two pretty important things when you look at the quality of care as well as just fiscal sustainability and the morale on the staff that currently exists in the facility that knows they are making a lot less than the agency and the staff person that's coming in from the agency. It's not a healthy dynamic.
It's and I apologize. I might be having some audio problem based on a couple of things I see in chat. I don't know what's going on here. But just thinking about what Sam and Angela heard discuss. Costs more, provides less, picks off the existing employees. Now, what in that picture is any good whatsoever? It's really a crazy approach to delivering service. First of all, I've always wondered why that when a nursing home says they can't afford to hire staff or keep staff, they're paying their existing staff maybe $16 an hour, certified nursing. But yet somehow they find the money to go out and pay a temporary agency $30, $35, $40 an hour for that same person that they couldn't afford to pay more than $16 for. Something in this picture just has never made sense.
But can I tell you something, John?
Please.
They don't have the money, and that's why they're closing. That's why they're in financial ruin. They have to, because these people live in their care for 24 hours a day. They can't just put them out on the street or say, come pick them up. They're legally required to provide care. So they find the money, but then it leads to financial ruin. They have to decertify beds. They have to close down. They have to change their service lines.
They got to avoid this financial ruin that you allege by simply paying their existing employees rather than $16 an hour, maybe $18, maybe $19, and avoid paying $35, $40 an hour to be temporary stacking. Again, the math just has never worked here. Don't understand.
So, speaking of math and pay and staffing issues, we've talked about the issue of Medicaid funding with the state. The state has, at least in recent years, including this year, increased Medicaid reimbursement rates for nursing homes. I guess. My question is there a disconnect, I guess, between the increased funding that nursing homes are getting from Medicaid and the pay? I mean, does that need to be reworked? Does there need to be something spelled out in future Medicaid increases that say that look, this money needs to be directed toward direct care workers. This money needs to be directed toward, salaries and benefits or compensation.
So we've seen that happen. CMS just this year, as a part of one of their rules, included a pass-through, a direct care worker pass-through, where a certain amount of the Medicaid dollars allocated has to go to direct care workers. And I think that in general, I think that's great. I think let's raise wages. Let's find a way to do it. Let's increase funding and make sure those dollars, a percentage of them, are going into the pockets of those caregivers. But I think we also need to consider that providers aren't homogenous. Every organization has its own way that it does things, has its own way that it provides care, has different levels of acuity, has different education levels of the workers that are in their communities. And so I think we need to be careful with how much we stipulate where those dollars have to go. But I think in general, it's something that we should all be supportive of, increasing direct care worker wages.
I'm happy to hear Sam say that. So I would hope in the next legislative session, when it comes time for legislators to appropriate dollars to nursing homes and other long-term care facilities, rural organization, Leading Age, and the other professional organization, the Iowa Healthcare Association, I would hope that they would both step up and support what consumers have been asking for years and years and years. And that is just what you observed, Tim. When appropriations are made, saying we're going to allocate a certain amount of new money to this industry, and all of this new money has got to go to raising the wages of the workers who we can't currently hire because we're not paying them enough, or to get them in the door, they leave because they can find a better paying job down the road doing something that's a whole lot easier than working. So I think if we all came together, consumers and employers, and said, yes, we got this problem, we got to deal with it. They're going to appropriate some new money, require it to be used for worker compensation, specifically workers' wages. And then we'll go a long way towards solving this workforce crisis that we've been trying to deal with for 20 years.
Yeah, I mean, I think it's a good idea. I think we need to think about where to place the gas mask, though, like what comes first. And to me, closing that gap between the cost and the rate comes first. That 8% gap that's killing providers who don't want to take on Medicaid patients because they know they're going to lose money. And then they have to raise their private pay rates to cover those gaps in cost to make sure that their revenue streams even make sense at the end of the month. I think let's close that gap. Let's make sure that rates keep up with how much it costs to provide care. And then, yeah, let's stipulate how much we're giving to our direct care workers.
And I think the other aspect here is there are very few people in our, maybe a half dozen, who truly understand where all the money is going that's allocated to the nursing homes. There are cost reports, and I've been in some meetings with the Department of Health and Human Services over the years that boggle your mind how money is reported in categories reported, well, where all this money goes. I don't think anybody in the Department of Health and Human Services is really dissecting those reports that they can see decent analysis. So I think before we simply accept the facts that the industry, I think we need to step back and say, where does all this money really go? How much of it is going to profit for owners? How much of it is going to overhead? How much of it is actually going into the pockets of the accountant? How much of it is being siphoned to pay for related parties nursing? That might be a pharmacy, might be a laundry service, might be a lawn care agency that are controlled and owned by the same corporate entity that the nursing home is paying dollars to. Nursing homes, I'm going to say they're losing money via creating super sophisticated accounting mechanisms. Really not losing money, but it looks like they're losing money.
Sam, is that something that you can answer? Where is all this money from Medicare and Medicaid going?
I think it's a great question. And I think transparency is incredibly important when it comes to taxpayer dollars. And I think when you think about a large corporation that has lots of revenue streams in multiple states, there's not a lot of transparency there. And that is definitely something to be wary of. But outside of cost reporting, there are a lot of checks and balances in place for nursing homes. For instance, the payroll-based journal reporting has individual audits that allow a small percentage of error, and if providers are off, they lose stars or they lose funding. The data that drives Medicaid and Medicare based on a resident's level of care is submitted via the minimum data set or the MDS, which undergoes audit processes through CMS, state survey agency, and state Medicaid. Coding errors are addressed through lots of different mechanisms, including deficiencies and reports. So, though, yeah, cost reports, sure. I'm sure that there's research that exists that shows issues or disparities with the accurate information in cost reports, but there's lots of other checks and balances in place when it comes to both the federal level and the state level. I also just want to say that my providers, they're nursing homes. Firstly, they're required by federal law to submit 990s. So if you want to go look at their financials, it's public information. I can show you where to look. But I just want to say that, well, our providers, they're mission focused. They're not lining their pockets with public dollars. I do think that prioritizing understanding where that money flows is important.
All right. Sam, yesterday, the Iowa Attorney General, Brenna Bird, joined a multi-state lawsuit challenging the Biden administration's new nursing home staffing mandate. 21 leading age state affiliates, including Iowa's, joined the lawsuit with 20 state attorneys general to overturn the Centers for Medicaid and Medicare Services staffing mandate. Why did leading age Iowa join that suit? What does the staffing mandate require of nursing homes, and what impact is that going to have on Iowa's long-term care industry?
Yeah, I really appreciate this question. We decided to join the lawsuit for one reason, because we want our providers to be able to continue to provide the high quality care that they already do. This staffing mandate is humongous, it's sweeping, and it's a one-size-fits-all approach that was developed in states where the demographic is far different from how Iowa is. Between 2022 and 2023, according to the Iowa Board of Nursing, Iowa lost 5% of its nurses. As far as we know, only a third of those have been replaced. That's a huge number. So part of the CMS staffing mandate requires an RN on staff 24 hours a day. And while a lot of our providers have like a charge nurse or maybe their MDS coordinator is an RN by trade, it has to be someone else. In Iowa, it's simply a math problem. We support high quality. Let's do everything we can to make quality better in nursing homes across the United States. But having one set of rules for every single state and every single provider within that state is not the way to do it. Before you're punitive towards providers, you have to make sure that the workforce is there and that the people exist. We simply don't have the demographics to keep up with what it's stipulating, and providers will lose funding because of that. For our providers, they would love to be staffed 100% of the time. They just can't find the people. They rely on temporary staff. We already don't have the people. Before we make these huge sweeping pieces of legislation or rules that stipulate how providers have to staff, let's make sure the infrastructure is there.
John, do you want to wait?
I got to respond to that awfully quickly. Shame on Brenna Bird, shame on Lee Moines for thinking that a lawsuit to stop the right thing to do would improve the quality of care for residents in the world is stopping this well-intended action. Long-term food, quality life for people in Iowa nursing. It's not. 50% of facilities in Iowa already meet this standard that the industry is saying can't meet. It's impossible. I would just suggest that 50% of them are already meeting. Why isn't the industry stopping to take a look at it? What is it that 50% are doing? And why is it that the others aren't doing? This lawsuit is absolute BS. And it's real outrageous to be taken, particularly when these new requirements, they give the industry 3 to 5 years to get to the point where they can increase. I mean, you look behind the surface, you really got to wonder what the motivation of the Attorney General's on. And I'm really disappointed in legal aid. I used to think of that as a different kind of organization than really was the quality care of their clients. This sets a different message.
We're extremely supportive of quality care, and all of our providers will show that. We see this as punitive, sweeping action that doesn't take into consideration the unique workforce challenges in Iowa. We have to make sure that the infrastructure is there. We don't have the nurses. Nurses have been the #1 reported job opening on the Dial website since I started this job 2 years ago. We don't have them. And so before we decide to take these big pieces of action, we need to make sure that it's there. We're supportive of high quality. And we agree with you that well-intentioned is the right word, but this is just not the way to do it.
All right.
And everybody in Iowa child care settings have minimum standards for staff. They do that because it's the right thing to do to keep our kids safe. Now, apparently, we don't care enough about other items to have that same kind of criteria. I think it's a serious issue.
I think that if there was a staffing standard that was more tailored to the location or demographics of where these providers are, or took into consideration the current challenges being faced by providers, sure, let's talk about it. But this specifically is extremely overarching and the wrong approach.
This is a bare minimum approach, bare bones. And if with these bare bones staffing requirements, maybe they shouldn't be in business.
I appreciate the conversation, the discussion. Obviously, this is a very passionate issue. We only have about 5 minutes left, and I do want to move on. So I guess I want to talk about how can we shift public perception and make long-term care a more desirable career path for young people. You know, we've been talking about the staffing shortages. We've been talking about the funding issues, the pay issues associated with that. But also, you know, increasingly it seems like more people are not seeing this, right, as a desirable career path. How do we address that?
I think that I'd like to throw in the concept that we have not addressed the culture. And I think that we have a huge culture issue in Iowa. If you read some of these reports that come out that Dial does, you would be shocked at the way that these people are treated verbally, things that are said. And all of that, whether we want to admit it or not, is driven at an administrative down level. And if you don't have a solid administrator in that position, leading the charge, setting the right stage for the culture, requiring respect, all of these things, I mean, the whole quality discussion goes out the window. So I think that we need to really start focusing on some of these things that are not even related to money. Because to be completely honest, the things that we see on a day-to-day basis do not indicate that we are prioritizing and giving the right messages to the staff that are doing the work. And it's super disheartening, and it becomes an issue that's not just money. So I think that, we need on our end to increase our advocacy efforts. We need to have families that know what the rights are of the residents that are in the facilities, and they need to be active. I mean, that's really the bottom line kind of for us is what are the things that we can control? And a huge part of that is going to be a conversation about culture.
I agree with you. Like, God bless the people who are out there in the front lines doing a great job. There are a lot of caring workers who do this because it's a passion there. So they genuinely care about people, but they're not enough. And these people that are genuinely caring, you have some life realities that we have. They got to keep the roof over their head. They got kids to deal with. They got family members. And so wages, compensation is critical important. You got to get people, young people, particularly reason to go into this. Finding passionate people and also compensate them well so they will see it as this is a good job. I want to do this for a living. I want to do this for a coin. So if we pay them well, give them career pathways, career opportunities to say, I think we'll move all this in the back.
All right. Well, unfortunately, we have run out of time. I want to thank our panelists, Angela Van Pelt, John Hale, Sam Heibel. Thank you to our audience for your interest. Thank you to our sponsor, ITC Midwest. Next in our healthcare policy track at 10:40 a.m. Is Protecting Iowa's Healthcare Workers. And at 4 p.m., don't miss an exclusive live interview with former Saturday Night Live head writer and Iowa native Harper Steele. I'm Tom Barton. Thank you very much for attending.